So who knows what this painting is? Right, Sistine Chapel. So, possibly the most recognizable and most famous painting ever done. And the centerpiece of this painting is this scene, the creation of Adam, where God is touching the finger of, they're reaching out and touching each other. And I think it's very, is the mic on? Okay.
I'm going to turn it up a little bit though. So.
All right. And I think it's interesting that, probably the only other painting that may be this famous is Mona Lisa, which is a very simple painting of a woman's face. And that these two topics, the face and the hands, have such a high level of symbolism to us as people and such a high level of importance. If you think about our ability to recognize things, our hands are as recognizable to ourselves as any other part of our body, maybe even more so than any part of our body, because we see our hands all day long. And prior to mirrors or prior to people seeing their own face, they associated themselves with what they saw in their hands. So there's a very emotional attachment that we have to our hands, and it's because we see them all the time, we use them all the time, and when we have problems with them, it affects us not only on a level of pain, but also on an emotional level. It can affect you. So I think it's very interesting how much importance we have in our hands. So today in our talk, we're going to discuss the hand, and I'm going to talk you through some of the anatomy of the hand. The reason I decided to go into hand surgery and treatment of hand problems was basically because of the anatomy. It's such an interesting area to work on because it's very kind of a small, intricate. You have nerves that I work on. There's tendons, there's blood vessels, ligaments, bones. Every aspect of the body is really there in the hand almost. So, and then we're going to discuss general hand care and safety. So these are the common conditions that we'll talk about. We'll talk about fractures. We'll talk about arthritis. We'll talk about ganglion cysts and trigger fingers and also carpal tunnel syndrome. So these are probably the top five things that I see in my clinic. One other thing that I'd like to talk about beforehand, I don't know if anybody's seen this type of drawing before, but what this is this is a representation of two areas in the brain, the area where you receive sensation and the area where your brain sends out motor signals. And this shows the importance that our brain has for our hands. And if you could see here on the left, this is the amount of area that is dedicated to the hand. It's about almost one third of the sensory area of the brain is involved with the hand. This is the whole rest of the body, is the area that's the whole rest of the body sensation is about the same as you have in your hand. And then the face, and then the face is about the same as the hand. Then if you look over here, this is the motor cortex where your brain sends out the motor signals, and its even larger area is dedicated to the hand. And that's what allows you to have such fine motor control and motion of the hand, is that your brain is really dedicated nearly a third of its motor and sensory areas to the hand. So it's very important. So let's talk about the anatomy. We're going to start with the deepest part and work our way out. So the deepest part is the bones of the hand. And the main bones around the wrist are what's called the radius and ulna. You have 8 bones here that are called your carpal bones. The metacarpals are the main portion of the hand, and then the fingers have what's called the phalanges or phalanx. This is what a typical x-ray looks like. The only problem here on this x-ray, it's otherwise normal except that there's a small fracture here on the pinky finger. So let's talk about fractures. The most common fractures of the hand actually is the fracture of the wrist. So it's what we call a distal radius fracture, and distal means the most farthest part from the body. So the end part of the radius, and this is what the fracture looks like. Here's the fracture right through here. And this is the CT scan of a different injury, but this is where the fracture is. This whole area right here that's sitting up on here is distal radius fracture. These fractures occur most commonly in young people and older people. So you could see here the light blue is the males and the dark blue is female. And in the young population, ages 12 to 19, very common fracture in young men. And then kind of as we get into our 30s, 40s, and 50s, not that common a fracture. But then as we get older, it's a much more common fracture, and more so in women, and that's due to osteoporosis. This is an osteoporosis-related fracture. So there's two types of fractures of the radius. The ones we term the low-energy fractures, which are from a fall from a standing or a sport injury. And then there's the high-energy fractures, which occur from motor vehicle accidents, falls from height, and other crazy things, ATVs, motorcycles, and other dangerous vehicles. So this is this fracture once it was fixed. Because of the way this fracture was, it wouldn't hold in a cast, and the patient had to have a surgery to stabilize the fracture, and this is a plate and screws that's put in there. So this one's a pretty straightforward one, simple one, and then this one's a more complex one. So this is what a high energy injury looks like, where basically they blew up the whole end of the bone here and also got another fracture within the carpal bones. So it requires more advanced treatment to hold all these small pieces in place until it can heal. So what are the signs of a fracture? So signs of fracture are pain, swelling, bruising, deformity, and crepitation. Crepitation means feeling crunchiness inside your bone. So sometimes it's obvious, like this young man's fracture, but a lot of times it's not as obvious. It could be as simple as having pain and swelling and maybe no bruising in the wrist, and you could have a fracture. So it's important that if you have symptoms like this, and typically fracture pain is a little bit more painful than sprains or other injuries, that if you have something like that and it's fairly swollen, go get examined by your doctor, get an x-ray, and get it looked at. So like I said, sometimes they're obvious, like the one on the left, but the one on the right is also a fracture here, but it's fairly subtle. You can see there's just a little bit of change in the cortex here, and it's really not that, it's not that easy to see, and this patient didn't have very many symptoms. So the treatment for distal radius fractures is casting, and then also sometimes if casting won't work, we have to hold the fracture in place with either pins or hold it in place with plate and screws like we saw in some of those films. So why would we not treat them all just in casts? The reason why is because sometimes we're not able to completely correct the alignment of the bone, and you need to do a surgery to correct the alignment. Sometimes even if we're able to correct the alignment, it's an unstable fracture and won't stay in place with just a cast on, so it needs something stronger to hold it in place. Also, it's important to correct the joint surface. So you can see on this x-ray here, there's a nice smooth joint surface here, but sometimes that's disrupted with fractures, such as the one I showed you, that complex fracture earlier, and you need to do a surgery to realign the joint surface so the patient doesn't get arthritis later on. Also, stabilizing it with a plate can allow you to rehabilitate the patient earlier than using a cast. That being said, I still use casts for a lot of my fractures, probably most of them, but there are the ones that do need surgery that come along. So distal radius fractures, I mentioned osteoporosis earlier, and that this fracture tends to increase as people get older, and that's partly due to osteoporosis. Patients who have a distal radius fracture are 5 times more likely to get another osteoporosis-related fracture. So whether that's a hip fracture or a compression fracture of the spine, they're at much higher risk than the general population to get another fracture. It's important that if you're in the age group that you're at risk for osteoporosis, which is basically women past the age of menopause or men past the age of 55 to 60, that if you have this type of fracture, that you get, this is a DEXA scan. I think maybe people in this room have had one before, but this is what the results look like when you get a DEXA scan. And it's important that you get this if you've had a fracture to see if you have osteoporosis, because the treatments for osteoporosis are fairly effective in reducing your risk of a major fracture. Okay, so we did the bones, now let's go to the joints. So the joints are easy because they're basically just named for the bones that they connect. So the radius and the carpal bones connect through the radiocarpal joint. The carpal bones and the metacarpals connect through the carpometacarpal joint, and it just kind of continues like that. So the main issues with joints in the hand is arthritis. And the two most common types of arthritis in the hand, Number one most common is osteoarthritis, which you see here on the right side, but also fairly common is rheumatoid arthritis, which can affect the hands. You can see that these hands look fairly different. This one has arthritis, and it's mainly in the fingertips at these tip joints, and then here at these second joints. Rheumatoid arthritis, on the other hand, affects these joints. The main knuckles of the hand is where it typically affects, and also affects the wrist. So osteoporosis is usually at the fingertips. Osteoarthritis is usually at the fingertips, and rheumatoid arthritis is at the knuckles and the wrist. So arthritis basically means joint inflammation, and there's many causes, the most common of which is normal age-related wear and tear on the joints. Other causes are rheumatoid arthritis, like we talked about, but also other autoimmune diseases, gout, trauma, and infection. The most common places to get arthritis in the hand is the base of the thumb and also in the fingers. This is an X-ray and a clinical picture of arthritis at the base of the thumb. So typically it affects the patient right in this area, and what you notice here is that it decreases the patient's ability to bring the thumb out away from the rest of the palm. This is an X-ray which shows that, and this is a normal joint here, and this is the arthritic joint. And you can see there's no space anymore between here, and it's grown. This bone is not supposed to have this extra little spike here. It's grown a bone spur right along there. So that causes this limitation in motion, and this can also cause pain. The main signs of arthritis at the base of the thumb are pain in that area, weakness in the grip, and also limited thumb mobility. And also you tend to get, because of the limited mobility at one joint, you tend to compensate and get hyperextension of the next joint up. So people can end up with a thumb that's loose here and tight here. Most patients note that the activities that really cause them difficulty are opening jars, opening doors, that type of activity, kind of twisting things and gripping things. That's very difficult. The treatment is based on the symptoms and not the X-rays. So there's patients that I've seen that have had X-rays very similar to the one I showed you, very minimal symptoms, and have done well being treated in a brace or occasionally with injections or with anti-inflammatory medications. That's really the mainstay of treatment, is bracing, physical therapy to strengthen the muscles around the thumb, anti-inflammatory medications, occasionally injection of steroids to the joint to calm down the inflammation, and the last treatment option is surgery. There's multiple different surgeries that are done for this, but basically all of them involve removing the area of bone that's arthritic. These are an example of two of them. So on the left, you'll see that bone from the X-ray that we saw before, that little square-shaped bone. This is kind of the standard procedure. You remove that bone, and then you place a tendon or another type of tissue in here just to provide a cushion and prevent the arthritic bones from contacting anything. This is a second type of surgery that's done where you actually use an implant. This is a special type of metal implant that you use, and that maintains the space between these bones. So both of these surgeries are done. The one on the right is still fairly new, and I think that studies are still coming out on how well it is compared to the other one. But they're probably fairly equivalent surgery. The next arthritis topic I want to talk about is finger arthritis. So this is usually people mostly notice it at the most end joint of the finger, and what they notice is pain, sometimes deformity and crookedness of the finger or swelling of the finger, stiffness of the fingers, which is most notable in the mornings, and oftentimes people can develop this, a cyst here that's associated with the arthritis. So these are termed mucus cysts or ganglion cysts. I just like to call them cysts because I think mucus doesn't sound very good. But they're painful. They can result in a deformity of the nail or a depression along the nail. And they can be at risk of infection if they open and drain, which they will occasionally do. They result from, so this is an X-ray of arthritis at the end joint of the finger. And you can see this is the extra bone that's formed right here. This is a bone spur, and what happens is you have on the right here, this picture, this is the tendon that comes and attaches to that bone. And the bone spur irritates the tendon, and in response to that irritation, the tendon forms fluid to try and cushion itself. And that fluid can accumulate and form this cyst. So these aren't cysts that are anything bad. They're not malignant cysts, but they can cause discomfort. Mainly if they're bumped against something, they can put you at risk for infection, and they can also cause deformity of the nail. And that's what this is kind of showing as a nail groove. The treatment for these is, so for the mucus cysts, the treatment is to wear a silicone sleeve over the finger to try and decrease the tension on the tendon and decrease that swelling. The other options is to allow it time. Sometimes over the course of 6 months to a year, these will subside and go away. And then surgery for removal of the cyst and also removal of the bone spur to try and prevent it from recurring. The treatment for arthritis of the fingers is mainly not surgical. It's mainly symptomatic treatment. Typically, heat is very useful in treating these. And I think one thing that my patients have found very helpful is using a paraffin wax bath. And you could buy them at the beauty salon shop, things like that. And just basically using that in the morning when they wake up and have a lot of hand stiffness, and warming up the hands in that can be very helpful. Also, the silicone finger sleeves can be helpful. They provide a little bit of support to the finger and also provide some warmth. Anti-inflammatory medications. And the main surgical options for finger arthritis is a fusion of the joint is the most reliable. So that doesn't sound great. It doesn't sound great to fuse the fingers, but oftentimes that's something that you're not at until the finger already has very limited motion and is painful. So you change a finger with limited motion that's painful to a finger that has no motion at one joint and is not painful. So usually it typically results in better overall hand function for the patient, even though they have one joint that doesn't move after that surgery. So we'll move on to the next topic. So moving out from the inside and further out, we have the muscles and the tendons of the hand. So as you can see, very complex with lots going on. And like I said, that's why I like this, because I thought it was, there's always something new to learn. The main muscles that move your fingers actually are not in the fingers. So all the muscles that bend your fingers and straighten your fingers, they're all actually within your wrist and forearm area. So all these muscles back here are the ones that straighten and bend your fingers. The ones that are inside the hand itself are the ones that allow you to bend at these knuckles and do this motion, and then also to move your thumb in this type of motion. So it's kind of interesting that the farther out you go, the muscles are farther up here in your arm. And they run through these tendons that go out to the fingertips, and these tendons run through a series of pulleys that I'll show you on this next film. So they're called pulleys, but I think of them more like tunnels. Basically, you have two tendons in each finger, and this is showing you the tendons that bend the finger, and they run through this series of tunnels all the way to the fingertip. This shows an example of the other area where all these tendons run through a tunnel, and this is through the carpal tunnel. This is on the front side of your wrist, and the tendons that go out and help you bend the fingers, they run through this sheath right here, which is the carpal tunnel. So this view on the right is what we call a cross section, but it's basically as if you were looking at the end of a loaf of bread, as if your wrist was kind of a loaf of bread and you cut it and looked at the end of it. That's what this would be like, looking at the end of a loaf of bread. And you can see these are the bones here in the back, and then this tunnel right here is the carpal tunnel, and it has represent all the tendons that help you bend your fingers, and this yellow circle represents the median nerve. The median nerve comes through here and gives you the sensation to these fingers, the thumb, index, middle, and part of the ring finger, and also helps you move the muscles of the thumb. So that's everything that goes through the carpal tunnel. So back to trigger finger. So the pulleys of the finger, or tunnels of the finger, the problems that we can get there is mainly trigger finger. And what this is the tendon is surrounded by a thin film of tissue that helps it glide. It's a lubricating tissue, and sometimes that tissue can get swollen, and that causes it to catch within the tunnel that it's entering in. So the symptoms that people get, they get pain over this area, and usually that's right here at the bottom of the fingers is where people get this pain. And they also get locking or catching of the finger. This also is most frequently noted in the morning. When people wake up in the morning, they'll notice they have a finger that's locked down and they have to open it back up. The most common finger affected is the ring finger. The index finger is next most common, then the thumb, and then the middle finger, and the small finger is very rarely affected. And the treatment is splinting to rest the tendon. Sometimes this can allow the tendon area to decrease its swelling and begin to glide again. Injection of steroid medication around the tunnel is about 50% effective in completely resolving this. So meaning resolving and it not coming back. However, 50% of those patients this does return in usually around 6 months to a year's time. A second injection will again relieve about another 10 or 15% of these. But there are anywhere around 30% of these that can't be solved with injections. And for those patients, surgery is recommended. And it's very straightforward surgery. It's release of the pulley. So this is the pulley that's here, or I should say the tunnel that's here that this glides through. And the surgery is to go down and open up that tunnel. Fortunately, it doesn't cause any limitation in function. You have another 4 of these tunnels and 3 more crossing tunnels that hold everything in place so you don't run into any problems or any deficits with this type of surgery. And it's usually very, very effective. Despite surgery, somewhere around 5% of people will still have recurrence after surgery. So let's talk about the nerve anatomy. So the main nerves that give you sensation to the front part of the hand is the median nerve, which we talked about, and the ulnar nerve. On the back of the hand, you have a third nerve that comes in, which is the radial nerve, which gives you sensation there. These 2 nerves do all the muscles to the hand and also the main part of the sensation. This is the same slide that I showed before, just emphasizing that median nerve comes through the carpal tunnel, and that's an area where patients can often have problems with it. So carpal tunnel syndrome is compression of the median nerve at the wrist area. The cause of it is unknown. It's caused by increase in pressure within the carpal tunnel, but we don't really know what sets that off and what begins that. We do know that patients who have hypothyroidism, rheumatoid arthritis, or also diabetes are at increased risk of getting this. And that's mainly because these tendons, like I talked about in the finger, they have this lining around them, and that lining can become swollen and increase the pressure on the median nerve. And that's what causes this. So diabetes, hypothyroid, and rheumatoid can cause an increased swelling in that tissue lining. This is a picture of a hand that has advanced carpal tunnel syndrome. This is not the typical presentation, but what you can see is if you look here, it's a little bit difficult to see in this projection, but you can see that there's flattening of the muscles along the thumb side of the wrist. Multiple things can cause this. This can also be caused, like I mentioned, from the arthritis at the base of the thumb can give this appearance, but this is slightly different. And the reason this happens is because the median nerve becomes so compressed as it comes through the carpal tunnel that it's unable to send its signal onto the muscles here, and the muscles actually shrink and some of the muscle fibers will die away. The main symptoms of carpal tunnel syndrome are pain, and that's typically within the fingers most commonly noted are the thumb and the middle finger, but it can also be the index or part of the ring finger. Nighttime symptoms is the most common, meaning patients awaken from night with pain in those fingers. They typically say they need to shake out the hand and get the blood flow back, but it's actually getting the blood back to the median nerve. The common things that cause this, people know during the daytime, are driving often precipitates this, reading a book or reading a paper where you have your hands like this, doing activities like crocheting or typing. And besides the numbness, patients can, if it's fairly advanced, notice weakness in the thumb and really difficulty bringing the thumb out and around to reach the rest of the hand. The first line of treatment is using a brace, and this is typically prescribed to use at night. This is fairly effective in relieving symptoms, especially those nighttime awakening symptoms. The other treatment options are a steroid injection to the carpal tunnel, although this is less effective than it is in other things I mentioned. So like I mentioned in the trigger finger, 50% of people with an injection will have complete resolution of the problem and it won't return. In the carpal tunnel, this will give temporary relief for almost everybody, but still over 75 to 80% of people will still have symptoms at 1 year's time. Surgery is kind of the definitive treatment, and it's very effective. There's two methods to do it. There's an open method, which is the traditional way to do the surgery, and then there's an endoscopic method, which has been done for the last 15 or so years. These are
What's endoscopy?
endoscopic means using a camera to go inside, and instead of making an incision directly over the area you're working at, use a camera to go inside and look at it and do the surgery that way. I'll show a video of that in a second. But good question, thank you. So on the left is shown the incision that's used for endoscopic. It's a small transverse incision here at the wrist. For the open surgery, the incision is here in the palm directly over the carpal tunnel. So that's the difference. The incisions are a tiny bit larger in the open one, but not much larger. Other than that, not a huge difference. So this is a picture of what an endoscopic carpal tunnel release is. So you make this incision here in the wrist. You go underneath inside the carpal tunnel with this instrument, and this is what it looks like when you're inside. So this is the transverse carpal ligament that creates the roof of the carpal tunnel, and then you divide it. And I have a video. Let's see if. So this is the surgery. So you go in with the camera, and this is a little rasp that's used to clean off this lining tissue to make sure that you only have the transverse carpal ligament there, and that you don't have any nerve or any tendon or anything else that you don't want to be in your way. This is a probe that you use, and that's used to identify the very far end of the ligament. So you go down, you can see then I hook the very end and feel the end of it. And then you go in with a knife. Yeah, I'm sorry. Is anybody getting woozy? There's no blood. There will be no bleeding.
So that's cutting.
So you pull that back towards you and cut the ligament with it. You'll see in 1 second.
Blood?
No, no blood.
Pure fat?
It looks like it.
Is it cartilage?
It's not cartilage. It's ligament. So it's yeah. So basically, and that's it. And so then you go check the very end and make sure you get every last little bit of it. Yep, that's more of the ligament. Yep, you open up the ligament and create space. So that way the nerve isn't compressed. So you check real carefully, make sure you get each last little bit so you don't leave anything still pressing on the nerve.
How big is that knife?
That knife is about, what could I relate it to? It's tiny. Yeah, the tip of it's probably smaller than your straw. That little hook is smaller than the opening of your straw. That's how small it is.
Like a crochet hook?
Yes, like a very tiny crochet hook. These surgeries are, carpal tunnel is very effective at relieving the symptoms of carpal tunnel, especially the nighttime symptoms. For patients who already have, like I showed that picture of the atrophy of the thumb, they may have permanent nerve damage and you may not get full function back of that muscle. But it's very good at relieving the pain symptoms, especially nighttime symptoms.
Well, the doctor said he'd do my carpal tunnel and he'd make a slit and he ended up cutting a couple of inches. I mean, was that because he had to go in and do it different?
Yeah, so if he was doing the open surgery, so this is kind of a typical incision for open. It can be a little bit longer than this. It's not uncommon to need to go, maybe
Twice that long.
almost twice that long. But it depends on the thickness of the hand and how kind of pliable the tissue is the hand. If you have a thick, very tough hand, yeah, then typically you need to make a longer incision. Usually the incision length doesn't make a big difference. What makes a big difference for the patient is that you make sure you release the whole ligament and that you don't leave anything compressing on the nerve. So recovery is anywhere from 3 to 6 weeks to get back to normal activities, probably a little longer to get back to high demand activities. Some patients may still have tenderness in the palm, even up to 12 weeks. Recovery with the endoscopic approach is a little bit faster, 1 to 2 weeks, but I wouldn't tell my patients, you're going to be back doing everything tomorrow if we do this endoscopic. That's not the case. So I just wanted to give you guys a couple resources. This is a great resource. This is the American Society for Surgery of the Hand. This is their homepage, and I like that on their, on the very top bar, on the first thing they have, and in a different color so you can see it, is the For Patients tab, and you can go to that. You can go to that tab, and it has a nice, it talks about a lot of topics that are useful about the hand, hand safety, hand and arm conditions, hand anatomy. And they have a symptom checker where you basically go in and you highlight hand and you say, I'm having pain in this area or numbness in this area, and it can help you kind of identify what's going on and give you an idea of things you could do before you have to go to the doctor. It has hand safety, and these are the things that it talks about for hand safety: fireworks, lawnmowers, snow blowers, pumpkin carving, turkey carving, gardening, removing a ring. So these are all very common things that we see injuries from. I said fireworks is probably the least. Lawnmowers, surprisingly common. Snow blowers, even more common. Turkey, even more common. So, be careful with all these things. Be careful with your table saws and band saws. So some general hand care that I would give you. So use of gloves is, I think, number one thing that's important. So not only, say, like for us in a hospital setting to prevent infection, but proper use of gloves for the task that you're doing. So if you're gardening, wear a pair of leather or heavy cloth gloves that are going to protect your hands from getting cut, getting poked with thorns, or getting blisters, things like that. Or if you're doing, if you're cleaning, wear rubber gloves to prevent irritation from cleaners or from water. Use of heavy hand cream each day, I think, is very, very important. I think something that comes in either a tub or a tube is good. If you could squeeze it out of a pump, then it's too thin and it's not good enough. So I think Aquaphor and Eucerin are both very good ones. And I never had a patient have an allergy problem with those. I think they're good and do a good job. Maintaining the strength of the hand is important to just daily, work on the motion of your hand. Fully do a couple sets of fully opening and closing the hand. If you have a squeeze ball, you could squeeze it when you're not doing something else with your hands. Also, placing a rubber band around the fingers and work on opening the hands can also be very useful. A lot of times people run into issues with weakness in the muscles that open the hand because we seldom use those, and that can be very helpful.
What are the 3 types of pinch?
Oh yeah, 3 types of pinch. So there's basically 3 main pinch functions that you have with your thumb. So you have, this is basically your what we call fine pinch, and this one we call, this is called a chuck pinch because it's kind of like a chuck key for a drill. You pinch together with 3, and this is called your power pinch, which is between here. So if you have hand therapists sell putty that you can work on these with, but you can also just buy silly putty or one of the squeeze balls and work on those 3 types of pinch, and this is very helpful for keeping the thumb strong. But those are the main 3. That's the main 3 pinch functions that our hands do. For hand injuries, very common, jammed fingers and things like that. Ice is usually useful for the first 48 hours, and then heat after that is useful in restoring the motion to the fingers. I think soaking the hand in warm water for 10 minutes 3 times a day after injury is a very good way to loosen up the hand and help you get the motion back. For the hand, motion is better than immobilization. So with some injuries like the wrist and other areas, we tend to immobilize them longer in a cast or in a splint to allow the area to heal. But the fingers do not tolerate being immobilized long. They tend to get stiff, they stay swollen. So we're really trying to err on the side of mobilizing the patient early and using modalities to decrease swelling. Hand therapists are very useful, and I've really been instrumental in helping patients to keep and regain motion following injuries. Elevation for the hand is really one of the best things you could do after injury. It's always hard to keep your hand elevated because we use them so much. But when after you have an injury, try and use the time like when you're sleeping or if you're sitting down to elevate your hand above the heart level. And when you're walking around, likewise, you can elevate it on your other shoulder to keep it above the heart level. And that will help with, not only help with the pain and the throb that happens when you get an injury in the hand, it will also help you keep the motion because the swelling won't be there. If you have pain that's not resolving after your 48 to 72 hours, it may be a fracture or maybe something more serious. So it's a good idea to get those things looked at. I think that's it. Thank you very much for having me and coming and listening.